here. Hold on to it till later. And for those virtual, raise your hand. We will then, like with the raise your hand function. Thanks, Dr. Krell. With the raise your hand function in Zoom, and we will call on you. So that being said, allow me to introduce Dr. Ferguson. So Dr. Ferguson is a graduate of the Cornell University Medical School, and he did training at North Shore University Hospital and at Mount Sinai in Connecticut in internal medicine, and he has a very long and distinguished career in academic medicine. Most recently, for the past 20 years, he's been a clinical professor here in the Department of Medicine at the University of Maryland School of Medicine, and he's the director of the Dean's Professional Enhancement Initiative, which he'll talk to you a little bit about. Now he divides his time between the School of Medicine and the Greater Baltimore Medical Center, where he supervises our Maryland medical students. And he also is founder and editor-in-chief of the Journal of Community Hospital Internal Medicine. Perspectives, I guess it's J Chimp, right? It's a nice, and in this capacity actually teaches medical students to peer review, which I think is a wonderful, wonderful skill to learn for everyone. So with that being said, I will turn over the podium to Dr. Ferguson. I will be back here to facilitate conversation.
Thank you for that nice introduction, Chris. This is the second time I've done the psychiatry program. Some of you may have been here, even the last one was about 3 or 4 years ago. And these cases are very similar to the ones that were put together. And the cases are all true cases that residents in the program participated in. So we think that they're very relevant and real world. So what we'd like to do is have a resident read each case. We have up to 11 cases to discuss, depending on how much time we have, and read each case and then open it up for discussion, both personally and virtually. So can we have a reader for the first case? I think our chief resident has already volunteered to do that. Yes. Yep. I think I can. You got it. Okay, that's not the right slide. Yeah. Okay, here we go.
All right. So case 1 is you are the PES overnight resident and get a call from the ER for a consult.
Some of these like PES, can you explain that? What PES means? Some of the who may not be.
Okay.
Yeah, I don't know what that means.
Okay. So you are in the psychiatric ER overnight as the overnight resident and get a call from the adult ER for a consult and potential admission to psychiatry. The adult ER is consulting about a 78-year-old lady with a history of chronic schizophrenia. She is suspicious of all medical staff, agitated, and talking to unseen others. Her vital signs are stable and labs are within normal limits except for bacteriuria. The adult ER says they have started the antibiotics for a UTI. When you ask for the reason for admission, they say that the patient has psychiatric symptoms that her adult living facility can no longer take care of. You tell the adult ER that you are planning to come and evaluate the patient, but are unsure that this patient would be best suited on a psychiatry service. You go to see the patient and confirm paranoid delusions and hallucinations, and you tell the ER team that you agree the patient should be admitted to the hospital, but think she would better be suited on a medical service first, due to the need for antibiotic intervention and treatment of UTI-induced delirium. You suggest the CL team can follow the patient during the admission and continue to provide recommendations for delirium and behavior management. You are immediately told by the ER team that they have already spoken to the medical team and that the plan was to admit to psychiatry due to the psychiatric complexity of the case. They are unwilling to have any further discussion with the medical service, and they suggest that you are providing too much pushback. They insist you admit the patient to a psychiatry unit. So the first question for this case is, how should you, as the overnight resident in the psych ER, handle the situation?
I asked, okay, pretend that today I know we would just admit this patient. That would be the issue, but pretend it's like this is someone we don't feel comfortable admitting.
So we don't feel comfortable admitting to psychiatry. Okay.
Anybody like to open up the discussion? We'd open up everybody about handling this situation. Has this ever happened to any of you here? Probably has. It's happened to me a lot when I was on the medical service at GBMC and Union Memorial. Go ahead. Yeah, but why don't we get the mic over there?
Hi, I'm Kelly. I'm a PGY4. To answer Dr. Ferguson's question, I haven't been in this situation personally, but I was hoping to kind of start the discussion by answering number one, like how should you handle the situation? I think the first thing I would do is try and get a better understanding as what conversation was had between the ER team and medicine team, and to get a better understanding of what medicine might have said and why they continue to push for a psychiatric admission. That would just
That might be turned up a little. It's hard to hear.
Okay, I will try and talk louder. Is there anything you need me to repeat?
No,
The whole thing? Okay. Okay, so, oh, so closer? Okay. I don't.
almost like you're eating it.
Almost like I'm eating the mic? Okay, so is this better?
That's better.
So my answer was for number one, how to handle the situation. My first approach would be to better understand what conversation was had between the ER and the medical team, what the ER said, what the medical team responded with, and if that led to the reinforced request for psychiatric admission, just to better understand what's going on.
Okay. And I guess what follows is how do you approach admissions that you do not feel are appropriate for inpatient psychiatry, if that's the case?
So to answer number two, how would I approach admissions that I do not feel are appropriate for inpatient psychiatry? In my experience, I've learned that being very firm with our answers and providing reasoning and data is the next best step. So just off the top of my head, one of the criteria for inpatient psychiatric admission is if all other reasons for the psychiatric symptoms are ruled out. And so we have very high suspicion with proof that this is bacteria and they're starting antibiotics. So there's a clearly identifiable reason for her symptoms, and that would not constitute a psychiatric admission because there's something that can be done before an admission would need to happen.
Anyone else like to put in their 2 cents here? Okay,
Oh. I was just, let me take one now. Something that, oh, someone's raising their hand? Dr. Gorelick?
Yes, my experience may be out of date, but during my training shortly thereafter, for some years in Southern California, when I worked in psychiatric ERs, I would just expand on the answers already given, which I agree with, but try to talk with the medical team about what their concern is, because there's a lot of almost fear, stigma about dealing with the psychiatric patient, especially one who's agitated. And I think I would try to find out exactly what resources they feel they could get from CL service that would make them more comfortable, as well as, of course, as was just said, firmly saying this patient is not appropriate for psychiatry because of the delirium due to UTI.
anyone else?
Dr. Van Renner.
Hi, I was going
Dr.
to add,
Van
and then Meg actually preempted me by putting in the chat, but the first thing I would do is actually go in person to the doc box in the ER to discuss in person with the team. I find that when we try to have these conversations over the phone or over Tiger, especially Tiger, it does not go as well as if we just go in person, provide the empathy to the team that tends to be very frustrated with the situation. It goes a lot smoother than when we're explaining our reasoning and why the patient's not appropriate for our inpatient service.
Actually, I think that's a pretty profound thing is, and this is kind of a generational thing. We're so used to texting now, and we will say things in text that we probably would not say to someone's face. And you end up you have more arguments via text because you don't sit there and look the person face to face. So.
Hello, this is Dr. Dodi. One of the senior attendings, and I did consultation in my previous jobs for 10 years. First thing, at that time being a senior attending, the medical residents used to listen to me, so I have some advantage. I generally tell the residents, delirium is nothing but brain failure. You pay so much attention to heart failure, kidney failure, brain failure is a medical emergency. It has to be handled properly, otherwise the consequences can be grave.
Yes.
The only other thing I would add, I guess two things. One is that it's always helpful if we have very clear guidelines that what the inpatient service can manage and what they can't. So we can relay that back to the ER. We can't manage them with an insulin pump or whatever the specific is. The other thing I just want to point out to the residents is you're not out on a limb by yourself. You're the PGY1, you have a senior to go to who can help out. And there's an ER a psychiatry attending you can go to, because sometimes there's an imbalance when you have the emergency room attending talking to a PGY1 psychiatry resident.
Well, that's a great point. I wonder for the residents, because, we get immune to that time. Would any of you as a PGY1 be comfortable telling this to a ED attending, or even as a senior resident, would you be comfortable having this discussion with an attending in another department?
Hi, I'm Erin. So yeah, I think as a PGY1, I think I wouldn't have had the information that I needed to have the discussion. I think that you do need a lot of background on like what the inpatient unit can handle, what the medical service can handle. And I definitely would have sought help from my senior to go through those nuances. I think as like a PGY4 senior, I would feel comfortable having the discussion with the attending. And if there was still like a very significant amount of pushback and I felt like I was kind of hitting a wall and really explaining as much as I could, then I would probably reach out to the attending. But yeah.
2 a.m.
I mean, I've still done that. I think, yeah, for cases that I really felt strongly about not admitting to the medical or to the psychiatric unit, I would call the attending at 2 a.m. or shock trauma transfers.
I'm a junior faculty now, Katrina Escuro, but I was a PGY2 in PES a few years back, where a patient was not really ambulatory. He was like a frequent flyer, and everyone just thought that he was doing his thing, like coming back to the ED and with SI and auditory visual hallucinations, but he got to the point where he had even like urinated on himself in one of the Jerry chairs, and it just seemed very odd for this guy who I had seen a couple of times before. And so there had been, I think, an altercation with security a day or two before that. The attending happened to be someone that I had rotated with on like during my PGY 1 year, and I asked him, something seems different about this. Can you please come over and assess him yourself? And it turned out that he actually had a hip fracture, and they transferred him back to the emergency room. So I think just, asking for an assessment and asking specifically like what their recommendations are. So like Dr. Ehrenreich said, that you can say what can be managed on the psych side and what cannot be is more clear for everyone.
Okay. Let's go on to case number 2. Volunteer to read.
Dr. Van Remmen and another person had their hands up. So
Oh, I'm sorry. For the last case?
Yes, I had mine up, and just quickly, I'm as senior as you can get without being dead. And I am the director of CL, and I have had People stare me straight in the face and tell me that the patient was psychiatric after I have clearly demonstrated, at least to my mind, that there are a lot of things that are not psychiatric about this. And the important thing is often not to let one's own emotions get invested into the back and forth so that you wind up saying something stupid, which is what happens a lot because people feel trapped like they have to respond. And often the best thing to do is to say, I'll go talk to my attending, or I say, I will go speak to the park office or whoever it is that I feel like I need to talk to. I'll go talk to my chairman. I don't care, but get out of the situation before the emotional pressure makes you do something that you really will not want to have done.
Okay, anyone else?
And Dr. Van Remmen, I know you actually, yesterday were in a similar situation.
I was, and talking to people in person made it much better. I just wanted to say, whoever I think it was Dr. Morano actually was like, oh, would you call the attending at 2 a.m.? I am the PES attending. Please call me at 2 a.m. If you have even the slightest thought, maybe I can call the attending, please call us. That's exactly what we're there for. We're there to provide that backup, to provide the information you're missing. We get paid to be on call. Please use us. Anybody who is nervous about that, do it.
Okay, anybody else? I don't see anybody else. Let's go on to the next case.
Thanks. Who's going to read for us? Dr. Nagel?
So you are a senior resident supervising overnight. You've been busy working with the intern, and the PGY2 took an admission on the geriatric unit. A nurse from the unit comes to you upset about an interaction with one of your residents. She states that she had wanted to clarify a Haldol dose with him that seemed very high. When she asked him about it, he said, well, I'm the doctor and I make the call. He then abruptly turned and walked away from her. She clarified the dose with you, which was, in fact, far above a dose recommended for an older patient. You let the nurse know that you'll talk to the resident about both the error and his interaction with her. She then tells you this is not the first time she's felt he has behaved unprofessionally. Another nurse comes into the room who was familiar with the situation last week and tells you she's had a few bad interactions with the resident as well. She states he is often dismissive of her concerns about a patient's clinical status or safety, that he frequently uses profane language in public places where a patient might be within earshot, and she has overheard him giving counsel to a patient that made her feel extremely uncomfortable. After her prior interactions with him, she didn't feel comfortable telling him that his counsel was inappropriate, but she did inform the attending at the time.
Very common situation. 5-10 people who may talk to the nurse like this. I can think of a couple. I don't know. No. I'm joking. But this does happen. And as attendings, we hear this all the time, complaints from nurses about residents. Yeah. So
Well, I think there's a couple issues. One is just the dosing of the medication, which I think is easier to address directly with the resident. It's pretty objective and you could educate the resident. I think the issues around behavior are a little bit more complex, and you'd probably want to gather information and then go to Dr. Ehrenreich and his team and let them know what you're hearing and have a discussion about the best way to approach it. I would not just go right to the resident based on this information. So a couple thoughts, but I would talk to them about the dosing. I think that's important. Easy to take care of. Someone should talk to them. That's for sure.
I think everyone's graduated by now, but I know we did have a situation where the senior resident did talk to that PGY2 that night. So is there anyone who feels that they would need to address that in real time? And I'm not saying one's right, one's wrong. I think there's many ways to approach it.
I guess I agree with Dr. Weintraub that like addressing the acute issue of like the medication dosing is important. And I would definitely do that first and see how they handled that feedback first. And then based on how they handled that feedback, decide if I was gonna kind of launch into addressing kind of the interaction between them and the nurse. And yeah, and then I think, yeah, I would see how they took the first feedback, and then kind of knowing how we take these things now, I think I would probably, as the senior, take it to the chief resident and let them know so that they can escalate it to the training office. We have like a weekly meeting, and we typically will discuss resident concerns in that and see if this is a pattern and address it if it's kind of becoming a pattern. So, yes.
Dr. Enright?
The boss has a,
The only thing I would say is that in the training office, we want to know this information. And it sounds like the attending had some information, the seniors have some information. I think it's actually not unusual or unreasonable to address it directly. But I would probably ask the question. The nurse had some concerns about how you addressed her. I wonder if you can tell me about that interaction and get their perspective, just so you ask their perspective. But professionalism issues don't go away unless they get addressed. So we like to hear about them early.
Dr. Rockbeisel, a nurse and physician.
So I don't disagree with what's been said so far, except that there is a thing called a teachable moment. And there's nothing like real time to really recognize. I mean, we don't know what this resident's going through. Maybe he's had a really bad night, 4 admissions or 10 admissions, whatever. We really don't know. And so I think I would have done step A, which is what Dr. Weintraub was, figure out the medication and then explore with the resident, why you pick the dose and blah, blah. You could do the medication piece. But then I would say, you know what? This seems to be a difficult moment. What's going on? How's your night going? The nurse seemed upset. You seem a little upset. Can we talk through this? So in the moment, understanding what is going on. I don't mean to put my back to people. This is hard. But I think that there's a teachable moment where you can show some empathy, show some understanding, a full understanding of what's transpiring, share a personal experience of feeling irritated, frustrated. Certainly I've had my moments like that. My faculty can vouch for that. And then walk through it. And I think that is at times much more effective than waiting 2 weeks, going to the training office and saying, assuming this person was bad and unprofessional. Well, maybe the way they handled the situation wasn't absolutely professional, but what was the circumstances? So anyway, that would be my thought.
I have a question for people. One thing I'll say is please don't address these situations in texts. We've had that one too. Very similar. But I guess I have a question. What about the nurse? Because if you go to the resident, I'm just curious, you're basically outing this nurse, that this nurse is complaining about this person who probably will have to work with this resident every night for the next 2 weeks to a month as night flow. What about that? Is there anything we need to take into consideration in how we address this with the resident and our, and the nurse?
Yes.
So maybe something I would do even before talking to the resident and engaging in a teachable moment is to talk to the nurse and gauge her comfort with how much she wants us to divulge about the situation. Like, does she prefer anonymity, or is she okay kind of revealing that this interaction happened?
Anyone else on this case? I don't think they can hear you. Right?
Take care of it. It's not really real time, but it's not 2 weeks later. We try to, and I hear what Jill's saying, because it can happen that way, but try to get to Mark quickly and say, hey, this happened. But yeah, I think it's hard to know. Yeah. So I think the initial addressing it initially, you have to be focused on that particular incident and not bring in this other data that you don't have information about, like this person said this 2 weeks, there's a history. It sounds like that goes along with this resident that I wouldn't want to address. But I think as Jill said, if you focus on that specific incident, then you're probably okay.
Okay, let's go on to case number 3. Need a reader?
The other of our chiefs?
So you are the second-year resident on an inpatient service, and your attending is being particularly single-minded on one of your medical students who is applying into psychiatry. She is pimping her,
Buy that.
asking questions very aggressively, repeatedly, basically putting the student on the spot.
I just want you to know that when I was your age, they were pimping people then as well.
On rounds and not giving the student a chance to answer all the questions. You have a lot of confidence in your student's medical knowledge and know that she could answer every question if given the opportunity. After the session ends, you also note that the attending misspoke and imparted some erroneous medical knowledge to the team during that discussion.
Oops. We don't have discussion points on that one.
So first question is,
Oh, maybe don't?
I can read it. Okay.
Okay.
So there's 2 questions, and one of them is, how do you diplomatically reteach the salient points from the rounds, particularly those that were misinformation? And the second question is, how do you address the student who is feeling very shaken in her confidence about her medical knowledge and previously told you that she wanted to stay here for training?
Anybody?
How do you feel as residents when when you see a medical student maybe having a rough time with the attending?
Pathetic. I think I would try to talk to the student after the interaction. Sometimes when I've seen that, maybe more off service in the first year, but I try to tell the students that sometimes you're learning what to do and what not to do from people when you're training as a student or a resident. And then kind of have a discussion with them about the medical knowledge afterwards, and then kind of pass on this attending's name and the interaction to the chief resident on the service that I'm on, in hopes that that kind of makes its way.
I think it also, and this is Dr. Doherty, it also depends on the attending. I generally keep reinforcing, just don't take it what I say. If you have information, if I'm teaching you something wrong, please let me know, or say, according to this article, this is what is going on. With some reasonable knowledge you have, I won't let the attending get away with giving the wrong information. At least I would encourage, but most of the times I think the residents are intimidated, they don't speak up. Sometimes they write in their comments at the end of evaluation, but rather than bringing it up, even when you are encouraged, when you encourage them to bring it up.
Well, let me follow up on that. When any of our residents, you're rotating with Dr. Doty, he said something wrong. What would you say to him in round? Would you say something in rounds? Well, get the microphone and elaborate. Or okay. Go
Oh,
ahead.
yeah,
All
here.
right. Whoever,
Eric.
Nisha, it's fine.
Okay. I think I would say when the attending comes back, or if rounds are still going, I would say, oh, I was looking at up to date and this is what I'm seeing. What do you think about this? That's probably how I would give the information that I'm seeing.
I have a follow-up question. Would any of the residents feel comfortable going to the attending after rounds, not in front of anybody else, and simply say, medical student A, I've worked with them a lot, and I think they know all those questions, but it's hard for them on rounds when they're rapid fire, and I don't think you're getting a good view of her medical knowledge. I mean, would anybody feel comfortable telling that to an attending?
I think it depends on the attending.
My name's Valerie. I'm a PGY2, and I think one of our roles, obviously, we're learning so much how to care for these patients, but we have a really big responsibility towards the medical students, especially someone who's interested in psychiatry. And it would be such a disservice to them if, because of these poor interactions with an attending, they start thinking about not going into this career. So I think it's first really important to continue to build up that med student, especially pulling them aside multiple times and saying, I'm really impressed by what I'm seeing by you. And you don't want to smack talk the attending, but just validate the med student that this looks like it's been really tough for you and this attending is being particularly brutal with you. I don't know if I would feel comfortable telling the attending directly that I think their behavior is questionable. I think it would depend on my rapport with the attending and how well I know them, how much have we worked together. I've been appreciative when attendings ask my input about sub-Is and medical students, and give me that platform to share my concerns and then also just share praise and what I've seen the student do well. So I would say attending wise, that's like a nice thing to consider is just asking the residents their thoughts about the med student.
Anyone else like to add anything?
Would anyone approach the attending?
I'm Trixie and I'm a CAT fellow now in a 4th year. And I would at this point in my career, but I don't think I would as a 1st or 2nd year. I think at least when situations like this arose, I would talk to a senior resident about what happened and sometimes ask them for like help or tips with how to approach the attending and then go about it. But I think at that point in time, especially in your career where you're working long shifts, really burnt out, really tired, I think a lot of my attention would be more focused on the med student like Valerie had brought up. And I would be worried about like how saying and going about it the right way with the attending.
This one small follow up on that. What would you as a chief do if you were then given this information? Jamie, Valerie's complaining a lot about me. So what do you want to, what are you going to tell me or not?
I would probably, I'm Jamie. I would feel comfortable bringing it, like starting the conversation with the attending, being like, oh, like just kind of giving a general, like asking a general questions like, oh, like, so we have these medical students, like, how do you think they're doing? And kind of starting the conversation that way. So it's not like, oh, you have been treating them horribly, like, you know, so like kind of starting inviting the attending to kind of give me more feedback and kind of thinking about what are some of the things that we can, like if something needs to be fixed, like what are some things that we can work on together and kind of opening up the conversation that way.
Again, Dr. Dowdy, I would not let an attending get away with misinformation. We all can do mistakes when we are teaching. So I know it is delicate to talk about the student, how the attending is treating the student, but if the attending gives wrong information, you should bring up the article, you should bring up what you know, in a way, saying, I reviewed, I think somebody else said this before, I reviewed this and this is what I see, and give them an opportunity for the attending to correct it. Sometimes after several years, some of our medical knowledge can be rusty, medical events. So I think it is important not let the attending get away with providing wrong teaching about some subject.
Good point. We do get rusty. I'm only a PGY 22. I don't know about, Dr. Doty may be a PGY 40. So we do get rusty, please.
I agree. I agree with what Dr. Doty said. Like if there was a misinformation, I would probably talk to the attending, like in a private place and ask for clarification. And if there was a mistake made, I don't think I would like educate the medical students myself. I would kind of give the opportunity for the attending to kind of correct the information.
Is that it, Chris? Okay. Another reader?
Case number 4, you're seeing a follow-up consult in shock trauma who was admitted for a serious suicide attempt by ingesting razor blades. Before entering the room, you see a sitter scrolling on her phone in the corner with headphones in her ear. You see silverware next to the patient's finished meal tray, despite recommendations to the team that the patient not have access to any sharp objects or silverware. The first question, how would you deal with this situation?
Something has to be done.
You guys see this all the time.
I think the first thing I would do is take the silverware away. So yeah, I think kind of like making the scene safe initially, and then after you have ensured that everything is safe, you can kind of address each piece after that. So I have personally spoken to sitters before, and kind of filled them in on the severity of the situation, and have said something like, hey, I just want to let you know that this patient is a really high risk for hurting themselves and really needs to be watched very closely. And then, so I would address them directly, and then I would also speak to the charge nurse and kind of let them know that the sitter doesn't seem to be like fully focused on the patient. That's where I would start.
Anybody
If
have
the
this
pedal-
experience? Go ahead.
If the patient's also getting metal silverware, then something might be wrong with their order. That needs to be addressed with the primary team too.
Anyone else?
Who would call out the sitter? Because I mean, we see this all the time. Sitters on phones, sitters sleeping. Do you as residents feel comfortable to call out a sitter? Or do you go to the nurse?
Yes, go ahead.
Dr. Ziera.
I think it has to do with patient acuity. If it's somebody who is going to, you are concerned that they're going to hurt themselves in the hospital, absolutely. But if it's somebody who has, you know, a one-to-one because they said something, but we don't really think that they're going to escalate their behavior. But I think it depends on the patient.
Okay.
Excuse me,
Sorry.
I'm going to chip in here that there are specific ways that you should report dangerous situations like this where policies haven't been followed and there's a problem, because when something like this happens, it often reflects some problem with how things are being addressed systemically. So there's something called an unsafe report that you can file in our hospital so that this will get addressed and looked at by higher ups rather than just depending on your report and your ground level intervention. Ground level intervention is a great thing, but if we've got systemic problems, like we've got sitters who aren't trained, we've got staff who are lackadaisical, we've got people who aren't reading the dietary precaution orders, that stuff needs to be addressed, and it's beyond resident or faculty individually. So we can actually do a lot of good by making these reports.
Yeah, and having done multiple quality of care reviews for swallowing, actually by putting in an unsafe about sitters, it really brought attention to the hospital that everyone in the whole hospital is struggling with this issue with sitters, and they're going to change some of the ways that sitters are trained and get sign out as a result of this. So, all right, Dr. Van Remmen. Oh.
Yeah, so I was just gonna say, I feel bad when we say like call out the sitter, because sitters have a very boring, long job and they're not paid well. It's just like a fact. We know this. So I try to instead like engage them in the patient's care. So usually when I walk into the room and there's a sitter, I ask them like what their name is. I make sure that the sitter and the patient know each other's names because frequently they don't. I ask the sitter how the patient's been doing, you know, in front of the patient. We kind of like work together and try to engage him as a member of the team instead of just like a robot who's sitting there staring at the person all day. And that usually I find makes more of a difference than anything else, because like yelling at them is obviously the opposite of like building a team. Like we're trying to build that they are an important part of patient care and part of that patient's team.
Just want to add a little bit about UMSAFE, which I review all the UMSAFE reports. We get from here about 30 to 50 a month of UMSAFE reports. And I would say at least 10% of them have to do with sitters. And often the ones that report them are non-physicians, non-residents, or often nurses who report them. So it is an issue, you know. Okay, very good. Let's move on to case 5. Inpatient unit. Resident arrives looking disheveled and breath smells of alcohol. Anybody like to pick this up?
I'll present this one. You are in an inpatient unit and your co-resident arrives late looking disheveled and their breath smells of alcohol. Your attendant calls in and states to start rounding without her. As you go about interviewing patients, you notice that your co-resident rushes through their patient interviews because they want to get back to the workroom due to feeling ill, and they phone into morning interdisciplinary rounds. You know your co-resident has been experiencing lots of stress recently, but you've never noticed these behaviors before. For the questions, 1, what should you do next? 2, do you let others know about your concerns? If so, who do you speak to first? And 3, if this was your attending or another member of the healthcare team instead of a co-resident, would you act differently?
All important questions. What would you do next?
Anybody experience this? Happens.
I think this case was just added in, so it must be fairly recently. So who,
Drunk resident taking care of patients, your attending hasn't come in yet. What do you got to do something, right? Or
Yeah, so, oh,
go ahead.
I think the first thing would be that they don't see any patients, possibly.
This is Nisha. I'd agree with that. I think that it's just very dangerous. I don't know what orders they're putting in. Like, their judgment is impaired, and your patient should not be seeing you in such a state. So I would be worried about patient care in that scenario.
so what do you say to the resident, your co-resident?
The first thing I would ask them is, I noticed that I noticed that you're different today. What's going on? Like, just try to get information from them and see how that conversation goes. It's a really hard scenario.
I think immediately too, you need to, the resident needs to go home that's impaired, and you need to step up and take over their patient care for the time being until the attendant comes in. So I think just like immediate damage control, that the resident needs to leave the unit.
You send them home yourself, or do you call Dr. Ehrenreich, or do you call the unit attending?
Yeah, and I think this is so hard because like as co-residents, a lot of us are very close too. So this could very well be one of your closer friends. So I think I would just directly say, hey, you don't look like you're doing too well. Why don't you head out of here? I'll take over your patients for right now.
I would probably do the same. I would say, like, you aren't feeling well. It doesn't seem to me like you're in a state to take care of other patients. Don't worry about the unit. Like, we'll handle it here. The same way, like if somebody has COVID or something, or like concern for that.
Any other options?
What would our training director like to have happen?
I actually do think this is a hard question. I mean, obviously I'd want to know, but I can imagine residents not wanting to tell me. And it's, it's your closest friend. What do you do? What if they come back the next day and look completely fine and you don't see it again? What if they come back the next day exactly the same? So, I mean, obviously I'd like to know if there's concerns. I think you could also talk with the chief resident, who's a level before me, if you wanted to get a sense of this has been seen before or not. But it's not good for the resident either, But maybe they just had a divorce and they drunk lights. I mean, who knows? I don't know what went on. But it doesn't mean that I would, immediately get rid of them in the program either, right? I'd explore it with them. So I would like to know, but I recognize in reality that I'm not going to know all these things.
Yes.
I think it's really important that the resident doesn't go to work. But this resident needs help. This is a red flag, right? We all know you don't go to work intoxicated. So this resident has a problem and they need help. So the point of telling the attending is to understand the situation and get the resident help. We don't pass judgment on someone that has a substance use problem. We get them help. So they don't need to be fired. I would yell at you or fire you if you fired them. But we do need to get them access to help. That's all.
Are we obligated to let like employee health know? Oh, go ahead.
Well, I could just say, because I
was gonna say.
I'm the head of the hospital's professional assistance committee, and I don't think I've heard of this in psychiatry, but it's definitely happened in the other specialties. So, yeah, I mean, obviously the first thing is worrying about, and it really, even if, because you don't know, you smell, they could have, their last drink could have been 12 hours ago. So they may not be impaired, but certainly the professionalism of, doesn't really matter. Then you want them.
This is Dr. Dodi, and in last 12 years, I came across a lot of residents especially, and I'm very glad to say I noticed very minimal problems with the residents. I never saw somebody completely being impaired and able to work. But I think I agree with you. If somebody is impaired, patient safety first, I would in a nice way say, it looks like you are not feeling well. I want you to go home. Let me take over your patients for today. If this is a pattern of behavior, if it is not one incident, I will definitely go beyond that, talk to the chief resident and even the program director. But if it is just one incident, he's good friend, he had a bad day, one particular day, I will say, I will cover your patients, or I will talk to the attending, and between both of us, we will take care of the patients. Don't worry about them. And I will tell the attending, so-and-so is not feeling well, so I asked him to go home. So I'm covering as much as I could.
Well, let me ask this. So what does, how does from the EAP perspective, what would you're kind of starting to highlight that?
If it is only one day, if it is not a pattern of behavior.
So you want to, like it's already been said, I mean, you can go to Dr. Ehrenreich, you can go to a chief. The point is you want to go to someone, because you don't know, even if it's your friend, but maybe it's not, and you don't know, and it could be the sign that something more seriously, the suicide rate in physicians is high, so you really don't want to not have done something and then something much worse happens to that resident. So yeah, there are a lot of, there are now these, what are they called? Or something. There are other residents and attendings in the hospital that can be contacted. There are a lot of different, the RISE is another, email me, there are a lot of, just reach out to somebody else and say, this is going on. Besides getting them out of the hospital and not seeing patients.
You know what, it just dawned on me, this reminded me, when I was in medical school, we had a group of, happened to be a group of guys, students. They were all like heavy partiers, and two in particular just got drunk every night of medical school. I don't know how, they were really smart. They got into orthopedic residencies, but I found out not too long ago that they actually both lost their licenses due to substance abuse from friends of theirs. I found that out early in their career. So this could be really a flag that something much more serious is going on, or not, but you don't know that. And it's sad that, and we all knew it. We all knew it. We all knew what they did, and no one said anything.
Great point.
Yes. Somebody?
Who's out there? Dr. Grelick? Or
Yes,
who has their hand up? I can't see it.
You calling on me?
Yes, your hand
Yes,
is up.
okay. Yes, it was. Speaking as a PGY 46, I want to emphasize what I think Dr. Welsh was saying. I recognize him only by voice. I don't see his picture about the AP. I wanted to emphasize there's a second responsibility you all have as physicians, and that's to our peers who may be in trouble. I don't think one episode of apparently showing up to work impaired, whether it be alcohol intoxication or some medical condition, can be swept under the rug. We owe it to our peer as well as to the patients and the profession to report that, obviously in a supportive way. I agree with everything that's said. First, you take care of the patients, you take care of the co-resident, you send him or her home, but then you have to mention it to somebody who could look into it, whether that's the residency director or the EAP, whatever. But I may disagree with Dr. Doty. I wouldn't let one episode like this pass. This could be a sign of something serious. And I think it's in our obligation to the co-resident themselves, as well as to the patients, to bring that to the attention of someone who could investigate further and get this person help before they, let's say, lose their license because of substance use disorder.
Any other comments on case 5? Okay. Move on to case 6. Need a volunteer?
You're a PGY1 rotating on PES days, that's psychiatric emergency services, and you and your colleagues are finishing up a long day in PES. You're listening to your colleague give sign out to the overnight PES resident. After sign out is completed, but while the team is still present in the room, the night senior, PGY3, approaches your colleague and provides critical and unhelpful feedback about her sign out. You're taking a phone call for collateral, but you overhear the night resident, senior resident telling the resident that her sign out is poor overall and that she needs to work on both being concise and on giving only relevant information. She tells the PGY1 that she doesn't want to hear about the day's events for a particularly sick and at-risk patient, despite the fact that you feel the intern is very appropriately informing the night team of this patient, how quickly a patient can become agitated and need PRM medications and security involvement. You disagree with the night senior's comments and feel that they are vague and did not provide specific comments or points to work on. Additionally, this feedback was provided in front of the entire room of people, other residents, attendings, nurse, and tech, rather than in a private setting, which you feel is very unprofessional. Number 1, what should you do? Number 2, who do you bring this up with if you didn't feel comfortable talking directly to the night senior about it? Should you bring it up to anyone else?
Any takers?
You're an intern, right? This senior comes on, not right. What do you do?
Hi, it's Jamie. I think I would first check in with my co-resident to see how they're doing. But as a PGY1, I don't think I would feel comfortable like confronting the senior right there and like right there in the room. I would probably bring it up to a chief resident.
Yeah, this is Isabel, just kind of adding on to what Jamie's saying. I think when I would check in with my co-resident and I would also ask how involved they would want me to be. Like, do they want to talk to the chief resident themselves? Do they want me to be there for support? Like, I think it's hard because you want them to like get the appropriate response from the program, but you don't also want to put their business out there without their permission.
Hey there, I'm Christian. I'm a PGY1 who happened to just finish his PES rotation. I agree with some of the comments made so far. I think I would first check in with my fellow PGY1 and just kind of gauge his or her reaction to what happened. And that was something that we often did, was just kind of check in with each other about how the day was going and thoughts about feedback we've been getting and how we think our workflow was going. And as far as like addressing the senior resident from the overnight team, you know, I agree that as a PGY1, I don't know if I would feel like I was in a position to like be confronting as far as the feedback that was given, but maybe I might approach that senior resident and just ask clarifying questions, or maybe ask for them to give an example of the type of sign out that they would be looking for. Or maybe I would go to a senior resident and kind of ask their guidance too. I think I'd be more in like a information gathering mode to try to clarify as opposed to confronting anybody about it. So I was just asked what I would say to Aaron as a senior resident who's just leaving. So I guess I would say, hey, I know I was on the phone, but I overheard a little bit of the feedback you were giving my PGY1 colleague. I just wondered, like, as far as giving a shorter sign out on this patient that had a lot going on today, which pieces of information did you feel were most relevant to present so we know like for somebody acute like this, how can we best convey that in a short amount of time?
Okay, next case.
Case 7. During a break on the inpatient unit, you and your junior attending resident are alone in the team room. Your junior attending resident openly ridicules the other members of the team, including the medical students, other resident, and the attending. He feels that the rest of the team is completely incompetent. He has had to double check everyone's work and thinks the medical students are an embarrassment to the School of Medicine. Question 1, how would a conversation like this with your senior resident make you feel? 2, what message do you think this sends? And number 3, how would you handle this conversation?
What's that?
Number 4, what is his DSM-5 diagnosis?
Anybody been around something like this? Okay,
Oh,
yes.
show I'm over here. It's Isabel. I thankfully haven't been in this situation as a psychiatry resident. I was actually in this situation as a medical student, as on a different service, which may be reflective of that service instead. But if I were like a PGY2 on an inpatient unit, I would feel very uncomfortable. I don't think I would have the confidence to address the junior attending who's a PGY4 in that situation. Probably would go to, I would hope that I would go to my chief resident. I think the thing that I don't know if I would do is, do I tell my co-resident? I think that's what I'm kind of grappling with, because you're in this uncomfortable situation. But I think I would go to my chief and let them know what's going on.
Everyone agree? Is that a good way to go? I think so. Why don't we go to case number 8?
Juicy here.
During your first year of residency, you were approached and asked on a date by a third-year resident in your program a few months after you complete a rotation that you were both on. 1, is it appropriate to accept the invitation? 2, what are the possible consequences of pursuing the relationship? And 3, if there's a low probability that you would work with a third-year resident again, does that change how you feel?
A lot of doctors met their spouses in medical school and residency, so it's not unusual. What's that? Yeah. See, when I was a resident, we had, or a medical student actually, but a resident later, we had 90% male in our class. It's changed. It's a lot different. We had 90 men and 6 women in our program. Does that change how you feel?
If you're interested in, pursuing a romantic relationship with this person, I don't think that that's inappropriate. But I mean, if you feel like there's a power issue with someone being a PGY3 and you're a 1 and you're like, oh, what's going to happen if I say no? That's, that's probably an issue. But yeah, I think that there are things to consider about having had, like, if something goes wrong in the relationship or you're working with this person who's your senior, could be a problem. But I think that that could be worked around, where you're not necessarily working with them, or because of conflicts of, relationships outside of the working one.
Anybody else want to chime in on that one?
Yeah, I think like we all have different dynamics with different people in our classes, whether it's friendships or family. So I think pursuing a relationship with someone in a different class, like Anna is saying, I think it would make it a little bit more complicated, but I don't think it's impossible to figure that out and kind of work through the nuances of that.
I just have a question, maybe for you, Dr. E. Like, would you, if a relationship is pursued between a 1 and a 3, and there's clearly a junior-senior dynamic, like, would you prefer we tell you so that we're not scheduled on the same shifts and stuff?
You hinting at something here, Kellen?
No.
So the major point is, I was the one that Anna had is there a power and do you have control over the more junior person in some way that you may, can you affect their career path in some way? Most of the time, I think as a 3 and a 1, the answer is no. You know, maybe you shouldn't be on call together, and then you should let us know or let the chiefs know, don't schedule us together. You know, I think it's more complicated when you get to attending resident, or which I think is the most complicated, and I think one I think is a problem. Resident students, which also happens, right? Well, I would argue with you. It depends on whether you're going to have a rotation with them, right? So you had a rotation, the resident's gone, the student's gone, and you're going to have a relationship, but you have no control over them. But if you are hitting on them while they're on your unit and you can do their evaluation, that's a real problem. And we actually had a resident years ago who traditionally asked every student who ever rotated with them out on a date, which was a real problem. I was not program director at the time, but I was aware of that. So
is it attending to date a resident even allowed?
I would say no, but I do know when I was a neurology resident, my neurology chief resident and the neurology attending who were in service with me were clearly together. And they did not hide it at all.
I can understand if they're in different specialties. Okay.
Anyone else? Okay, question, case number 9. Anybody?
Case 9, where is case 9? Oh, there it is. Okay. As a senior resident, you are approached by a third-year medical student who notes that he was asked, wait, this is similar, okay, who notes that he was asked on a date by a first-year resident a few months after completing a clerkship they were both on. Is this appropriate? And what are the consequences, potential consequences?
Similar scenario. I think we could probably.
You say, go for it. Why are you coming to me? Is that what you said?
He wants to know the psychodynamic underpinnings of why they're coming to ask your permission.
Okay, well, we got 2 more cases and then we're done. So let's go to case number 10.
Okay, case 10. You are on the CL service and one of your co-residents on consult service reveals to you that the incoming family medicine resident who's completing an elective rotation is his personal physician. The family resident is scheduled to start tomorrow. How do you deal with the situation and what do you tell your co-resident?
So is this a conflict or not? Anybody? Probably minor, I would think.
Yeah, I don't
Maybe
know
it
if it's-
depends. Oh,
Oh,
I'm so
go ahead,
sorry.
Sarah.
I'm from Zoom. I was just saying, maybe it depends on your co-resident, his health, their health status, and you may not be aware. Like like you may not know if they have a diagnosis or something that they are worried about that person knowing and being in the same room. Like there may be something uncomfortable that you just don't know about. So you may just want to ask your co-resident, or you may tell your co-resident to speak to the chief on the service, et cetera, if they don't feel comfortable being kind of part of that same team for some reason. I just know because from personal experience, I know when I had my baby over at Mercy, I specifically requested no residents part of the procedure because I didn't want to run into one of those residents again the next year as an attending here. I wasn't comfortable with that. So there just may be background we don't know about.
Okay. Anyone? All right, let's do the last case. Anybody want to do it?
You're the chief resident for the inpatient psychiatry unit, and you receive a call from furious charge nurse stating that your resident is being very rude and you need to come right now. When asked what happened, she tells you that the resident approached one of her nurses after finding out his patient had not been monitored on the CAL scale an hour ago as ordered. The nurse apologized to the resident, stating that there was a behavioral code and several difficult patients on the unit, and she lost track of time. You're also told that your intern then began to scream at the nurse, stating, "I don't see why it's so difficult for you to do your job." At this point, the nurse and the intern began yelling back and forth in the hallway, gaining the attention of other patients and other staff. Oh boy. What should you do next? How should you de-escalate the situation? What are the best ways to limit the chances of this happening again?
Tell them to stop yelling. That's one thing you can do.
You guys are all very nice, but this has happened.
How was that intervened with? Chris, I mean, do you remember that case?
I mean, I don't remember the specifics of the case. I know it was one of my co-residents who was really not very nice to nurses. I think it eventually got back to the training director, but I don't know if anyone intervened in real time. I always find, I think in this particular kind, you're the senior resident?
Chief resident.
Okay, so I think in that case, I wonder if our nurses are comfortable going to the chief resident. I think they probably are. I hope they're comfortable coming to me as the attending or as the medical director. Because the power differential is always a concern.
Yeah, I guess the first thing I would do is like separate them so that they're not yelling at each other in common spaces, and try to like de-escalate the situation, and try to understand, like just listen to each side and try to understand like what happened first, before doing anything. But this is a very challenging situation.
Anyone else? Okay, well, thank you all very much for your wonderful participation. And this is a very good teaching moment for all of us, I think. We're done.